So the title of today's session is Technology, Pathology, Radiology, Changing the Game through Neurodiagnostics. The premise being that advanced diagnostic technologies are shifting our fundamental understanding of neurological diseases. This understanding and these technologies are serving as the basis for a systems approach to diagnosing, intervening, and managing neurologic disorders. I was telling the panelists that 45 years ago when I started in medical school, they were all backroom guys, radiologists and pathologists, and now they're right out front with diagnosis and treatment. So my goal is to be a different type of moderator for this. First of all, I want the panel to sort of say what's on their minds and not rely too much on me asking questions. That's because I'm a psychiatrist, and I'm trained to wait and listen and to tolerate long, awkward silences. So I hope you'll help me achieve that goal. Sorry about the breathing. Don't know how, maybe I'll just move this down a little bit. I hope that doesn't disrupt anybody. So let me start by introducing our panelists today. First on my left is Jeff Golden. Jeff is the Ramzi Cotran Professor of Pathology at Harvard Medical School and Chair of Pathology at Brigham and Women's. He received his undergraduate degree at UCSD and MD from University of Pennsylvania, trained in anatomic pathology and neuropathology at the MGH, then postdoctoral training in genetics at HMS, returned to University of Pennsylvania, School of Medicine and Children's Hospital, CHOP, for his first faculty position and rose to the rank of professor there, where he established the Division of Developmental Biology for Pediatric Disorders at CHOP and was appointed Pathologist-in-Chief there. In 2012, he moved back to Boston to become chair of the Department of Pathology at the Brigham. Jeff. Our second Jeff to my left is Jeff Hersh. Jeff is the Chief Medical Officer of the GE Healthcare System, or GE Healthcare Systems, plural. And he's been there for 2 years, but has more than 20 years experience in the healthcare industry. He's had a number of national roles and has actually served as and still does as a nationally syndicated columnist with a column that's What's Up, Doc? Which is he's still doing. He continues to work as an emergency room physician and has held the role of Global Medical Director of Medical Safety, Boston Scientific, and has had faculty appointments at Yale, Dartmouth, Cornell, Tufts, UMass, and Harvard. I'll ask you later how in one lifetime you fit that in. And to his left is the chairman of pathology at the Mass General, David Lewis, who's the Benjamin Castleman Professor of Pathology at Harvard Medical School and Pathologist-in-Chief at MGH. This is an extraordinary department, and he's a really valued colleague of mine as an MGH chief. He has 100 faculty members in his department, over 100 trainees, 700 employees, performs 10 million laboratory tests, as well as 80,000 surgical pathology evaluations, 400,000 microbiology, all this yourself, you do, and 50,000 cytologies. This department has become a national leader under David's leadership. His own practice, his own expertise, specialty areas in brain tumors with an emphasis on the molecular basis of malignant gliomas and molecular diagnostics pertinent to glioma classification, and I'm sure we'll hear more about that during the panel. For the sake of timeliness, I'm not listing everybody's substantial publications and awards because we'd be here a long time. To his left, we welcome Sarah Moore, who's the Vice President for MR for Siemens US, responsible for managing all the MR-related business, including sales, marketing, service, customer experience, business development, and joint management of R&D collaborations with their headquarters in Germany. She's been at Siemens for 13 years in a number of capacities. Prior to that, she actually worked here at HMS in the Brigham in a research lab studying transcriptional regulation of cytokine-induced cell adhesion molecules on the endothelium, and specifically Krebs binding proteins, which brings us back to the brain.
Cool.
She has a degree in biochemistry, and more importantly, was a Division I NCAA women's basketball player.
I don't seem tall enough.
And lastly, to my left is my colleague at MGH, Bruce Rosen, who is a professor of radiology, the Lawrence Lamson Robbins Professor of Radiology at Harvard Medical School, and Professor of Health Sciences and Technology at the HMS MIT Division of Health Sciences. He is director of the Martinos Center for Biomedical Imaging at MGH, MIT, and the Harvard Medical School. He has a PhD in medical physics from MIT, in addition to his MD. Bruce's research over the past 30 years has focused on the development and application of physiological and functional NMR techniques. That's really an understatement of his importance to the field. I mean, Bruce and his teams, to my mind, are the pioneers in developing the technology and the resource of fMRI. His recent work has focused on the fusion of fMRI data with information from other modalities, including very high temporal resolution signals under magnetoencephalography and non-invasive optical imaging. And again, I won't go on and tell you all his awards and honors and numbers of publications. To kick off our discussion, I will ask Jeff Golden if he'd sort of give us a brief overview of the history of the changing role of diagnostics in neurologic diseases, and maybe give us a segue into what's ahead in the future, and then we'll open up a little more and talk with our panelists. To you, Jeff.
I wanted to challenge your idea of silence. So
he did that on purpose. That was good.
So thank you, Jerrold. What I wanted to do to just kind of set the stage for this was give a little bit of a historical perspective on diagnostics in the neurosciences field, and hopefully we'll be able to use that to kind of look forward to where we need to be going in some of the directions I think we want to talk about today. As I don't have to explain or justify to anybody in this room, the brain is probably the most complex structure known to man. And the way we've learned about it over the years was starting out years ago from really lesions, where lesions in the human brain showed us about function. There was this function and structural correlation. And that was really only done at the time of a postmortem. We really didn't know anything before that. And as time evolved, we started looking at what happened at the cellular level. So we went from the gross level to the cellular level. And so soon we started understanding that that lesion in that location, which resulted in function. And I want to keep to this concept of structure and function, because in the brain, more than really any other organ, I mean, if we look at the liver, regeneration of the liver, it still functions as the liver. But in the brain, it's these different regions. It's the systems, the function, these modules of the brain that we could understand if it was a vascular lesion or a tumor or a demyelinating lesion. It was the location that we could then start looking at what the functional consequence was. And then once we knew what that was, patients who came in with a functional abnormality, we could start to think about where it was, what it was doing, and start thinking about what the actual disorder was. As we got to the cellular level, we now, moving more recently, have started to understand this at the molecular level. So getting down at what genes, what molecules, what proteins are altered that cause tumors or now cause vascular disease or inflammation. And all of these, along with many others, have allowed us to get very sophisticated with what we do. And in fact, diagnostically, we've gone from that gross level to looking at the slide to now where we actually look at all the genes that are expressed. And the importance of the brain, I think, is highlighted by the fact that about half the genes in the genome are expressed in the brain at some time during either development or in the mature brain. And I think that in parallel to that, and I've really kind of talked about it from the pathology standpoint, which is my perspective, but there are other perspectives. And as we think about it from imaging, there's been a lot that has come together because now we have that same evolution from the gross examination of the brain, which we initially did with arcane studies like pneumoencephalograms and things, to where we now have these very sophisticated ways of looking not just at the structure of the brain, but now getting into the function of the brain. And that function is moving from just things like blood flow to actually doing molecular diagnostics with imaging. And so I think this is the evolution where these are coming together so that that structure and function, which is what we really need to understand neurologic disorders, can be tied together, and this really substantial relationship between what we do from a pathology standpoint with molecular diagnostics as well as the tissue diagnostics as well as the imaging can be put together for really extending where we go with understanding brain disorders and how to treat them, manage them. So I think I'll start with.
Well, that was a brilliant opening statement. I would give the other panelists an opportunity to comment, reflect, respond to what Jeff's summary.
Yeah, so I could not agree more. Coming from GE, where we're very centric, we're a technology and science company. But what we do is work with our partners, and that's extremely important. And we've worked with probably almost everybody up on stage, and that's extremely important to us. And when I think about this, I think about this from our life science business, where we actually look at the pathology. And what we're doing to support that from the science and technology is not gene discovery, but we're looking at this to basically support your mission, that is looking at the underlying pathology there. And so we're enabling technologies that'll help do transcriptomics, that'll help. The way I think about this is not only the regions of the brain, but also the timing of the brain, how it changes as the brain develops. So kind of like we say in multiple sclerosis, you look at it in time and space. Exact same thing. What part of your brain is doing what, and when is it doing what? And that's one of the things that we look at. And then we're also trying to work with our colleagues here to preserve that cellular matrix and the actual physical setup there. So doing multiplexed immunofluorescence. So it's not just what's going on, but you can also see which cells are going on. And then from the other side of this, we obviously do quite a bit of imaging, diagnostic imaging. And so I look at this in the big picture in the radioomics sense. And I think what we're going to see in the future is we're going to see analytics become a biomarker. And analytics in itself, how you put these together, will be one of the biomarkers of the future. And so when I look at that, I look at what can we do from the imaging side as well. And I think you heard Sue Siegel say we're working diligently on a head-only MR, which will have much more powerful gradients, which will be able to see things like axonal swelling, which may be a surrogate marker for brain plasticity. We're looking at PET. We're even looking into a wearable PET. So you'd be able to actually do PET scans while somebody is performing tasks and potentially be able to look at multiple PET markers at the same time. And then with Dr. Rosen here, I'm almost frightened to say anything about functional MRI since we have the world authority here. But I can imagine the future where our functional MRI not only looks at blood, but is going to actually look at firings of actual groups of neurons. But I'm sure you'll speak to that much more authoritatively.
Well, I'll just echo one point you made, which is a really interesting one, bringing up MS. It was in the lunchtime session. It was noted that in the area of MS, we probably made more progress than in any other neurodegenerative illness over the last 20 years. I think it's not coincidental that it was 30 years ago that people began to realize that MR could allow us to directly see and visualize those demyelinating lesions. And with that, decade investment in understanding its use as a biomarker, we suddenly had the ability to characterize the disease, watch its natural evolution, characterize which patients, had more rapid progression from others. And it became, I believe, an invaluable tool to allow us to get to the point where today we actually have many treatments for MS and of course others coming. So the hope is, as these technologies that you talked about come online, and of course not just in vivo imaging, but what we can characterize from a molecular basis, from a genetic basis, these will be the key biomarkers that will allow us to make progress for future diseases, whether psychiatric illnesses or other neurodegenerative illnesses, that until you can visualize what's going on in the disease, it's hard to know whether your treatments are really working and make a lot of progress. I think we've got a contribution to make there.
So you made the mistake of saying psychiatric disease. So the vision that and the progress we made in MS, starting with the ability to actually see the lesion and understand it, and in line with Jeff's description of how we can go from gross to molecular. It was an individual with the completely inapt email name of SHYMAN, Shyman, who was a former NIH Institute director, who a few years ago said, and you probably know what I'm about to say, that neuroimaging in psychiatry was modern phrenology. And so I wondered if you could comment on where that comment might have been right or wrong at the time, and maybe how it's changed and how it will change, so that the progress we've made in areas like MS and tumors might happen in our field.
Well, I think our first mistake was in colorizing those activation spots that we did. So we used to talk about the false color phrenology, our colleague. But I think fundamentally it came from not really understanding the illnesses. And of course, while we've made a lot of progress, there's still much more to come. But I think what we have learned in the intervening time since those comments is that most of the psychiatric diseases we're dealing with are complex and not single diseases. Until such time as we can actually characterize them in our patients, what the nature of the specific disorder is from a circuitry standpoint, from a molecular biochemistry and neurochemistry standpoint, from a genetic basis, the opportunity for us to intervene, whether it's through targeted deep brain stimulation, surface cortical stimulation, pharmacologic manipulation, is going to be extremely limited, because we're probably dealing with a very heterogeneous collection of diseases that we put under these labels: depression, post-traumatic stress disorder, et cetera, but which are unlikely to be single diseases. I think the real progress we've been making, both at the molecular level, at the cellular level, and at the systems level, that we might look at, with our tools, is hopefully going to allow us to characterize these diseases for what they are: individual diseases of brain circuitry, specific molecular pathways, specific abnormalities of receptor systems, receptor trafficking, and with that, better understanding of the specific diseases, hopefully target the treatments to the appropriate patient.
Right. So resolving them into circuits instead of little colored spots has been a big progress. And then, as you know, marrying genetics with neuroimaging to really create a gene-brain map is going on. And collaboration with you is probably going to help us get to that same vision that Jeff pointed out.
So maybe I could add two things to what Jeff took us through. The first Jeff took us through. Jeff walked us through the transition from gross to tissue level to molecular level. And he started out by pointing out that a lot of the original information about the brain was derived from autopsy studies, post hoc. It was all what happened, what did we figure out? The first point I would want to make is that diagnostics has really shifted now from post hoc types of analyses to really thinking as much as possible about prediction of disease, minimizing surprise, being able to take the breadth and wealth of information, whether it's at an imaging level or at a molecular level, and putting that together in order to predict disease course and predict response to disease. That's a big, I think, sea change in the way diagnostics is really being envisioned now. The second point I wanted to add was that we are highly, and again, it doesn't matter whether you're talking about the radiological world or the pathological world, we are highly technology driven. And when new technologies come about, we have a pretty remarkable ability to implement them in the clinical arena rapidly, perhaps more rapidly, and in many cases more rapidly than one is able to implement a therapeutic. And therefore, it's a very fast-moving field as we shift towards thinking more predictively and as we think about adding all new technologies, whether it's single-cell analysis or deep sequencing, whatever it may be, we can bring those on very quickly and start thinking about how they might impact patient care.
So has enhanced diagnostics led to revolution in treatment in your own area? Can you talk a little bit about your work with brain tumors and glioma?
The major area that it's impacted in brain tumors is a little different from the way it's impacted other common tumors. When we think about cancer diagnostics and predictive markers now, we naturally think about melanoma and targeted therapy there, or lung cancer and targeted therapy there. It's not there yet for brain cancers, but what has really changed the field is our ability to use molecular markers to diagnose things much more precisely. We're able to pinpoint the types of gliomas now or other types of brain tumors in a completely different way that we could in the past. And that enables us to begin to think about homogeneous types of these brain tumors that we couldn't think about in the past. And that's been very exciting.
I just wanted to pick up on something Mark said and also David. You know, Mark just said it took 30 years for us to come up with therapies for MS. And as we heard in yesterday's session, most drugs have taken 25 to 30 years. That's what they stated was the number of years it took. And it's those number of years that allowed for the development of the basic science to allow us to understand what multiple sclerosis was, that allowed these targets and movements of different types of therapy into the clinic. And what we heard from Mark around the characterization of specific circuits, along with what David's talking about for brain tumors and what we also are learning about Alzheimer's and other neurodegenerative diseases, that there are specific changes, profiles in the gene regulation, transcription, the proteomic landscape, as well as what changes occur in the imaging, that is allowing us to bring together in computational ways much more sophisticated biomarkers. It's no longer that your calcium's high or your glucose is high and that's diabetes. There's a complex set of biomarkers that are going to much more specifically stratify essentially all these different complex neurologic disorders. And once we start to do that, just as David was describing for brain tumors, where we then can look at a true single entity and start trying to work on how do we manage that entity until we've done that real careful characterization, that stratification based on these biomarkers that are going to be complex. They're going to be molecular, they're going to be radiographic, they're going to be all types. Only then will, I think, we be able to really make a lot of headway in these really complex disorders.
It's the area of brain tumors is especially interesting. If you look at the overall survival for high-grade gliomas, it remains poor, and yet there has been slow progress. Most of that progress, if I understand correctly, is not so much that each individual patient is living another month, but that there's this growing tail. There's a group of patients, used to be very few, now slightly more than that, who are living years, 2 years, 4 years, 6 years, even longer. Those are obviously a distinct class of disease that now hopefully we'll be able to characterize, whether through genomics, imaging, some combination through radiogenomics. know how to treat them, know how to understand that, and then of course grow that population. It seems like progress there is going to come from really being able to characterize what's special about those that now we've seen long-term survival on, and then to be able to bring more and more of the different types as we understand them on. MS is another interesting scenario, and Sarah, you will want to comment in terms of the improvement in technology. So it was MR 30 years ago that, made progress with MS. Now we're beginning to see with 7 Tesla MR, the next generation of technology, that now we're being able to characterize not just the white matter disease, but the gray matter disease, which the pathologists knew about, but, which we never saw radiologically before, which clinicians never really had access to. This kind of poor radiologic, clinical correlation in MS was in part because we were only seeing half the disease. So, I know that this technology is coming.
You finally believe us.
Yeah. We're slow, but we learn. Right.
The very interesting point, Bruce, that you bring up that I think is just really important to the science and the development as we move forward is the interplay of multiple modalities and multiple techniques to find these solutions. It's hard with a vendor hat on or an imaging hat. If your solution is a hammer, every problem is a nail. And it's easy to take a single modality approach when really the ability to advance the science is very, very dependent on the technology, the imaging technology, coupled with the diagnostics and cellular level and the genomics to create one pooled solution that ends up leading to an outcome. The hat I wear as well is a business hat. And one of the challenges, the key challenges right now we have in healthcare is that the healthcare system's changing. And so now we have to prove outcomes. It's not just about saying, hey, we think this is going to make a difference. We have to prove it. And that is a change in the way that we approach research and the way that we approach collaborations, both for our collaboration partners as well as ourselves, and how do we prove that a treatment really makes a difference, and it makes a difference early, and it makes a difference to a patient outcome, not just that it makes somebody live an extra day, or it seems like it's the right direction.
So the question for this panel, I guess, since we're focused on diagnostics, and you raised the issue of healthcare, is the cost of diagnostics in anticipation of better treatments borne by the healthcare system, or is this an academic or research enterprise? For example, I was at the MedCAC panel review of a ligand for imaging amyloid, which was turned down for reimbursement, not because it didn't identify amyloid and predict Alzheimer's or identify early Alzheimer's, but because they said it wouldn't make a difference. There were no treatment implications of the outcome. So I wondered, in this, as we tout the growth of these wonderful new diagnostics, I know David, you're building a biobank so that clinical resources will be a source, but what do you think of that dilemma of which comes first, sort of thing?
It's a really interesting one, the Alzheimer's, because if you ask patients and their families, even without a treatment, they want to know. In parts of the country when people, can afford to, get that data, they will, in many cases, choose to make that investment personally, because for planning purposes, for, any number of purposes, they actually want to know whether they, that risk is high. So it was interesting that they
So that point was made at the
Yeah.
panel. It didn't, when the votes came in, it didn't.
Didn't carry the day. Well, of course, the good news is we heard, at Biogen and others that it looks like maybe we're having a little bit more luck now than we did in that first phase of clinical trials. So it may be that we're, leading the charge, but hopefully in that case, not by very long.
Well, and imaging is going to hopefully be able to non-invasively also characterize the stages of the disease. So as we're hopefully going to find out, we all hope very soon with Alzheimer's, that identifying the disease early may be able to identify disease-modulating therapies that maybe are not so efficacious later in the disease. So as imaging can identify that, and as some of the beta amyloid and even the tau markers and some of the other markers that we're working on can identify the disease, that hopefully that'll help guide the pharmaceutical industry not only to what targets, but what stage of the disease to do treatments. So I can imagine later stage disease, you're really just looking for something that's going to help you symptomatically, whereas maybe early you're really going to be aggressive going after disease modulation.
And I don't think it's only guiding the pharmaceutical industry. It's guiding a whole set of other activities that eventually lead to progress in the treatment of the disease. And the other one that I think about, which is really essential for progress, is epidemiological studies, where just like in clinical trials, precise classification of what's going into the study is critical. It's a garbage in, garbage out kind of scenario. So the more precise you can be about the diagnoses going into any kind of study, whether they're clinical trials or epidemiological trials, is really critical to progress moving forward. That doesn't address the financial question, but clearly from a learning curve point of view, it's essential. One of the exciting things that's happening currently in the brain tumor field that illustrates this nicely is we are currently redoing the World Health Organization classification of brain tumors over the next year. And we are looking like we're going to be very successful in adding molecular parameters into the actual definitions of these tumors. The reason that's so exciting is not only does it help categorize individual patients for their therapy, but even more importantly, in some senses, it sets things up for epidemiological studies, for governments tracking diseases, for the insurers and whether they decide to pay for certain treatments or not. So we're actually making a lot of progress in the brain tumor field in a way that is fairly ahead of what other cancers are doing, because we're able to cross that second valley of death in the translational medicine sphere. You know, when you move from basic science to clinical, there's a supposed valley of death, and then moving from clinical into real implementation in a healthcare system. We're making that second jump in brain tumors, which should enable a lot of this classification to occur.
So I just looked at my iPad. We've got some questions. I think this one is for you, Bruce, or maybe Sarah. If you could have one novel next generation imaging modality reachable in the next 5 to 7 years, what would that be? And your caution not to enter the realm of sci-fi.
Yeah.
Which, in Bruce's case, it's not
I live on that edge, exactly. Excellent question. One of the things that I've seen throughout my career is that just being able to take a better picture sometimes just changes everything. We saw that when we first started doing MR, and then we could see MS, and when we started doing 7T imaging, and we could see cortical disease, and we could see epileptic lesions that were just missing. So I think that there's still a good way to go on MR technology. And while it may be a while, maybe a long while before this is something that sees widespread clinical use, I would like to see us go up to 12 Tesla or 14 Tesla, another factor of 2 in Moore's law. I think there are going to be some impressive surprises. To me, one of the most interesting things that we're kind of tantalizingly close to now is really being able to make this bridge between kind of system level things, the visual system, motor system, the kind of things that you were talking about that we learn about from lesion studies, and what we're learning about individual, neural circuits, and animal models, et cetera. A large part of the brain initiative that, the president started in his State of the Union was, focused on circuits. I just have this vision of being able to reach down into living human, down to the circuit level, which is obtainable. That's the level of the cortical column and the layers within the cortex, which means resolutions on the order of a couple hundred microns. We're already doing that in the best case scenarios anatomically. I think we can do that functionally, and if we could do that, that would be a remarkable tool, because then we'd really be able to peer at individual circuit functions literally the same way that the neuroscientists, the people doing optogenetics and all this tremendous advancement in basic circuit understandings, and do that in a living human. That will advance our understanding of the brain immensely, and I think that is an achievable goal in the next 5 years.
It doesn't seem fair that radiologists get to get down to that level, from the infinity to the néant, that you could cover the whole spectrum with your tools. It's like,
well, these guys keep moving further and further down into the genome. We're just chasing after them.
so clearly reflecting what a heavyweight you appear to be to our audience. this question says that our panel is heavily weighted towards imaging, and yet well, I guess the two of you are weighted towards imaging, but we certainly. So the question is, have we thought about blood tests for neurologic disorders like MS and other diagnostics? And I guess this would lead us to the topic of liquid biopsies, or what do you call it? Is that what you call it?
Liquid biopsies,
Yes.
yes. Do you want to?
Go ahead.
Well, it's a very interesting topic. So liquid biopsies are the use of primarily blood, but it can be other liquids like urine, to do cellular analysis beyond what typically a cytopathologist would do with something like a fine needle aspirate of fluid from somewhere. And the big areas within liquid biopsies are the analysis of circulating tumor cells, or cells in the circulation, and the big area that this has been pushed forward is in the cancer area. And then the other is free circulating DNA. My knowledge of this is restricted to the cancer realm, where at least for brain cancers, progress has been, I would say, on the low side. We've done some studies showing that in a small percentage of glioblastoma patients, you can pick up circulating tumor cells in their circulation. They're clearly tumor cells, they're clearly from the original tumor. And the attractive part about that is if you can boost the technology to be more sensitive and pick these up in a more regular way, that you may be able to avoid the need to do serial biopsies to find out in a brain tumor patient, has the tumor come back, or is the change that you're seeing on the imaging more consistent with a treatment type of effect. So I think there's a promise for it being helpful in the future. The progress so far has been fairly small. The same issue that's been talked about in other settings of getting drugs into the CNS with the blood-brain barrier comes up to some extent with getting things out of the CNS. And so we don't know what's necessary to disrupt the CNS to get more tumor cells out into the circulation, and you could very well argue that you wouldn't want to do that anyway from a clinical point of view. So that's what I would comment from a brain tumor perspective, Jeff.
Yeah, so I think that if you look outside the nervous system, if we start there, there's been tremendous progress in doing this kind of liquid biopsy in the prenatal diagnostics area. So today, there's actually many companies and there's many medical centers that are doing their routine trisomy 21 testing and other trisomies in particular. That seems to be the easiest thing to do. So trisomy 13 and 18, which are the most common three that you see, by doing these so-called liquid biopsies. You can separate out the maternal versus the fetal DNA. You have free circulating fetal DNA, and it's a pretty simple test to run. If you know the specific mutation you're looking for, in other words, if there's an inherited disorder, that's also pretty easy to do now, and there's a lot of people doing that, both in industry as well as in academics. If you want to do discovery, in other words, if you want to look at is there something wrong with the child's DNA? And again, I'm focusing right now on prenatal, and I'll move from there in just one moment. It gets a little trickier because it's hard to assemble the full fetal genome or even an exome in particular right now, which is what people are working on through these liquid biopsies. It can be done, but it's very difficult. So people have instead turned to the fetal circulating cells. And there's actually fetal circulating cells in the mom. There's actually a number now. If you can get 11 of them, you can actually sequence it, and you can do an exome. And that's what a number of different companies are now doing with 11. They'd like more, but the minimum is 11 cells. So we're moving into that territory. But I think that as we start thinking about neurologic disorders, there's a lot of opportunity for neurodegenerative diseases. So we're starting to recognize in liquid biopsies the ability to find tau expression. There's opportunities to see other types of inflammatory markers, which may be a method of following neurologic disease like MS with some of these inflammatory markers. So I think there's a lot of opportunities there. I don't think we're quite there for doing primary diagnosis in most domains, but for following disease and for being able to do some very limited, particularly prenatal diagnosis, I think there's already a place for that.
I would add to that traumatic brain injury. So obviously there's quite a bit of work being done to look for liquid markers, so maybe not liquid biopsies, but liquid markers there. And I think the conjunction of looking at some of the neuroimaging and then adding to that some of these other markers will be there. I also wonder with the existence now, at least we think of the lymphatic system, if indeed we are getting a dumping of certain, taking out the trash, if you will, and if that's going to be a clue, and we'll be able to actually find some of that within, within the blood and interpret that and see, look at those kind of systems for maybe other neurogenic diseases.
It's interesting. Apparently, all the questions from all the different panels are coming up on my iPad. So I was trying to figure out why they were asking us about autism and drug adherence but there's some interesting questions. if they are meant for us, let me know. But
maybe we can telecast over there.
One actually asking about the disease model of psychiatry, but I suspect that's for the psychiatric targets over there. So let me move on. Are there other topics before I pick one off our list?
I would just ask that, we've gone at both ends, so we've looked at the microscopic, we've looked at, the cellular level, and as you pointed out, we look at the functional. There's that area in between where we're looking at networks of networks. And I don't think we have a good enough handle on that. So I agree with what you said, Bruce, that we're now in imaging, we're able to get down to smaller and smaller. But I don't think we should neglect that middle ground either, because I think there's amazing amounts as we, understand connectivity better. We can map the connectomes, whether we colorize them or not, however we do that. I think there's quite a bit of information to understand there.
I think it's an excellent point, and in many ways it's kind of an interesting distinction or extension from where we are with cancer. With cancer, we've obviously learned a tremendous amount about the system biology, and we've all seen these beautiful diagrams with lots of pathways, and here's the mutation, and here we go, and here's where we can diagnose, and here's where we can treat. The challenge with the brain, of course, is that we've got those same kind of cellular level systems biology stories to work out. But in the end, the action of that abnormal cell is not necessarily right there in that cell the way it is with a tumor, but it may be on a distributed network. So really, I think the challenge of neuroscience is to connect the system biology of what we're learning about the genetics of receptor function, say in these large-scale studies, with the systems neuroscience of reward aversion, fear conditioning, the underlying systems neuroscience, because the changes that we're going to see happening at a molecular level manifest themselves in behaviors that organize themselves in these complex kind of network ways. So I agree with you. I think we're going to need both, and somehow come up with a cleverness to pull those tools together.
We're going to need to package what you just said and put it together in an educational format and get it out to society to help them understand that the brain is an organ like others, that it gives rise to cognition, emotion, behavior, et cetera, and that this is why it's so complicated. And brain diseases are not so different than other diseases in a sense, but they're just much more complicated.
Yeah. I mean, we now are learning about the parallels between ALS on the one hand and FTD on the other, and yet the behavioral manifestations are so different. What is it specifically about the systems neuroscience that is changing the kind of system biology impact of whatever may be these common genetic changes?
So just to add to what Bruce was saying, it's not just the connectivity in different locations, it's local connectivity. So if you think about the developmental epilepsies, there's a number of them that seem to be specifically interneurons. So the cortex, if you think of it in its simplest form, is excitatory and inhibitory neurons. And it's defects in these inhibitory neurons that have these local circuit defects that if we can figure out how that system is disrupted and what we can do to intervene there, you actually could have an impact on these devastating disorders. And that's the kind of level of understanding I think we need to get to.
But we also heard earlier from Ahmad Eskander on a panel that these are distributed networks, and if we can implant devices that can read overactivity in one part of the network and compensate for it in another and balance out the networks in a distributed way, not just locally, that might be a path to treat some of these disorders.
Yeah,
How do we resolve those?
Yeah, there's some fascinating data, for example, from Helen Mayberg that suggests that in patients with kind of the medically intractable depression, where they've had heterogeneous results, some patients respond dramatically and profoundly, others almost not at all. And it turns out, as she's studying it, when the electrodes are placed in a confluence of 3 pathways, I need another hand here, but there you go, exactly. If there's actually, and there are parts of the brain where you've got 3 divergent pathways coming, if you stimulate there, those are the patients that do well. And until we had the opportunity to even see these, complex, grids of crossing paths, we had no ability to even guide it. Well, now with the tools that, our partners are making, we can see that. And now we've got a plausible network-level biological target, and hopefully the kind of work that Ahmad's doing will show the impact of that.
And it's a very iterative process, I have to say, with collaboration partners and being on the industry side, because you develop these tools. The question before, Bruce, that you answered that I would echo about, we've got these really amazing tools with 7 Tesla, super magnets, and PET and MR merged, and there's these wonderful tools that I don't think we've really figured out how to master, and so there's so much opportunity in the tools that we have, and some of that iteration, now you can see these, like epilepsy is a great example, where we have an ability to see really small lesions, much smaller than we ever have before, in different parts of the brain. And so some of this is, Dr. Golden, to the point you made earlier about, hey, if you know where it is, you can map your way back to what their experience is, and iterate backwards. And so it's quite interesting to see how the technology enables that, but boy, in the hands of a physician or a scientist, the ability to make those connections is very, very important.
I think what makes the brain so tricky is this interplay between the electrical signals and the chemical signals. You look at the heart and you have your electrical and you have mechanical, and it's kind of easy to understand that. We see diseases, post-traumatic stress disorder, which can manifest with symptoms that seem like psychiatric symptoms, or you can have a stroke that'll give you a hemiparesis, but you can also have a hemiparesis status post a seizure. You can have hemiparesis for other reasons. Some people in their migraines can have a hemiparesis. And so that complex interaction there, I don't think we understand as well as we need to.
So I'm going to let some of the audience questions take over here. One is going back to the liquid biopsy and the comment about tau. So the question is, where is the source for liquid biopsy with tau expression found, in the blood or other fluid? I guess they're asking CSF or blood. You said blood. Somebody.
It's been in the blood.
Okay. So with all this high-tech stuff, here's an interesting. Are basic X-ray and CT scans useful, or should we have contrast-enhanced images with something overplayed MR info for utility? I'm an
MR guy, but CT is still the bread and butter of routine structural diagnosis.
So here's a question.
Jerry, just to,
go ahead.
I think there's also another general principle that's been highlighted by a couple of the last few comments. As the technology gets much more powerful, 2 things happen. You get questions saying, well, does this replace the other technology? And there are these real workhorse technologies that are often less expensive, less laborious to put into place. We have the same exact situation in pathology, where we always get asked, well, will this replace the standard slide under the microscope? And that's still a very efficient, cheap way and accurate way to make diagnoses. So I don't see that when these technologies arise, they necessarily replace the existing technologies in a global way. But the other aspect, and this was brought up by Sarah, is that as these technologies get more powerful, they begin to reveal things that you're really not sure what they are. And they create a lot of questions. And the area that we see it in that parallels that what you were saying is next generation sequencing technology, where we're able to look now at either patient's germline or patient's tumor DNA. And the number of alterations that we're finding is mind-boggling. And the significance of those is really an open set of questions. So I think the movement of the technology doesn't necessarily replace things above it. It creates many questions below it. There is an inexorable movement as the technology gets better and as it gets cheaper in that direction. But I don't think it necessarily makes stepwise jumps.
Thank you. So a question here is about traumatic brain injury from the audience, but it's one that you might have anticipated as well. Every year there are 1.7 million cases of traumatic brain injury in the United States and contribute to about a third of all injury-related deaths. Recent contributions to the body of knowledge on traumatic brain injury favor the view that multimodal neuroimaging using structural and functional magnetic resonance imaging, as well as DTI, diffusion tensor imaging, has potential to identify novel biomarkers and predictors of TBI outcome.
So this is exactly consistent with the NFL study that we're looking at, and looking at exactly that. So we're looking at, when we started, I made the comment that, there'll be analytic markers. And is it going to be one individual marker, or is it going to be a combination? And I think that's a great question that gets to exactly that point, that we're going to see combination of markers. It may not just be one thing, it may be a combination of those that are looking at it. And that's exactly along the lines, and I think, Sarah, you guys are looking in similar places to look at those combination of markers in specific diseases. And, Bruce, obviously you do this all the time. And looking at that combination.
We actually, to your point, had on 7T and 3T in the South, where there's quite a number of Army hospitals, they came to us and said they've got an issue with helicopter pilots and these brain injuries that happen over time because the gear on the head is 20 pounds. And is there a way to predict ahead of time with a helicopter pilot if they're going to have such issues long-term or if they're not? Because the Army would like to route those people different directions depending on what that result is. And so it's kind of a long-range, little bit alternate way of looking at brain injury, and can you predict brain injury with plasticity and other methodology using MR?
There's another great study being done by one of the young neurologists, Brian Edlow, who's been looking at very high resolution brainstem imaging using this machine that we developed as part of the Human Connectome project. Very high gradient strength, very high resolution imaging of tracks, where he's trying to be able to make predictions of who will recover from, especially in lesions of the brainstem that directly involve arousal, who's going to recover and who won't. And in much the same way that we learned about the basic system biology from lesion studies before, now we have the ability to be able to precisely identify these very small lesions in critical areas responsible for arousal, like in the brainstem, look at the associated tracks, and be able to essentially develop a personal connectomics. And I think that's yet another way that we're going to be able to use this technology at first to perhaps understand the disease, and then know if there's a particular nucleus and it's just not turning on or it's not connecting to something else, maybe that's a target for targeted deep brain stimulation.
So here's a question that's directed to, it says you and me. It's got to be you. It says NIRS, which I assume stands for near infrared spectrum. Laser-based wearable functional neuroimaging aims to perform world functional neuroimaging during people's daily activity. How do you think its potential to supplement traditional imaging modalities such as fMRI in various applications?
It's a very cool technology. So this is, some people call it diffuse optical tomography or near-infrared imaging. Red light and near-infrared light will actually penetrate, well into the brain and out again. The challenge is it scatters a lot. So, unlike an X-ray, which, mostly goes straight, the challenge is not getting the signal in and out. The challenge is trying to figure out where it came from as it's, bouncing around, like a pinball in the brain. But the computational technology is making great advancements, the ability to be able to see the photons literally, kind of femtosecond by femtosecond to give you an idea of exactly where it's passed. In other words, time resolution, that's technology is developing very rapidly. And the result is that certainly in children and in some settings in adults as well, we can actually do local maps, at least to the cortex, of brain activation using the same physiology that we use from fMRI, basically the change in blood flow and blood oxygenation. So we're using this in neonates now to be able to actually kind of do the brain equivalent of the pulse oximeter, but a regional map, of brain oxygenation, blood flow, oxygen consumption, and that technology is absolutely extensible in the future into folks like us walking around. So whether we'll ever be able to get the kind of resolution and deep brain imaging of fMRI, probably not. But I think there's a lot we're going to be able to learn, and especially for kids in development. Kids are frankly just less thick-headed than us adults, and that's a good thing for this technology. Putting a 2-year-old in the magnet is not so easy. But how do you want to learn about language development? The most human of all functions. Well, you need to be able to image kids when they're 1 and 2 and 3 years old. I think this optical technology is going to be fabulous for things like that.
So this may be a question for Sarah, but it's do the advancements ever bring the costs down?
Yes, they have to. And right now, unfortunately, with the collision of where healthcare is going and the survivability of health systems, we have to be a contributing partner in driving costs down. And some of that driving costs down is the right exam at the right time on the right patient. So some of our technology is helping enable health systems to do that, to image that way. And I'm sure that Jeff would comment the same. We're laser focused on making technologies more robust and less expensive. The idea of cryogenless magnets, looking at CT and trying to take the cost out of healthcare, not as relevant for a neuro discussion, but chest pain in the emergency room is very ineffective and very inefficient during the standard care pathway. And if you insert CT technology in that, you can change a paradigm. And University of Pennsylvania did phenomenal studies on this, just showing how you can drive cost out by using the imaging exams and using the test the right way.
Cool.
Certainly a lot of money spent on ineffective treatments because the diagnosis wasn't made right.
And repeat. You would be surprised. In fact, there's an interesting statistic that from a study where the advisory board looked at how often scans or studies are repeated. MR sequences are chronically repeated for patient motion or for mistakes or for issues along the way. And the cost of repeat exams in the United States is about literally a third of the total spend on radiology scans per year. A third of it is just the cost of repeating and bringing the patient back in.
That's enormous.
It's enormous. It is a significant cost. So how do we drive that down?
Yeah, get to work, guys. Fix that problem.
If you can non-invasively look at responses to treatment, whether it be with PET, you can see that, yes, the cancer is responding or not, or with neurodegenerative diseases. I think we heard earlier today, we heard one of the pharmaceutical people say, well, we'd like to not treat the patients who are not responding. Sometimes are they responding or not is a little bit difficult. You have obviously the placebo effect, you have other aspects from the patient. But if you could get a biomarker which is reproducible and which is accurate, then you can look and then you can obviate some of the treatments. So it may cost more in the imaging realm, but it may save money overall for the healthcare system.
Like hepatitis C.
Like hepatitis.
Yeah, would be an example. So this is probably a question from a VC person in the audience who wants some free advice. Could you comment on the future of imaging agents for commercial diagnostic purposes versus just R&D purposes?
So, part of that is going to have to go along with reimbursement. So as you know, as you spoke, there's now, beta amyloid imaging agents. As we get treatments, those are going to be phenomenal. There are some, Parkinson's disease agents, and I think it's going to have to go hand in hand with effective treatments. And I think the problem we're running into now is, as the pharmaceuticals have not had treatments, then although I agree with Bruce, that families want to know, the patient wants to know their diagnosis, they want to do some planning, so it's still incredibly valuable. But as a society, we haven't valued that as much as, well, does it lead you to an appropriate therapy, and can I see how it's going? And I think that's a problem in how we look at it as a society.
It seems to me one of the challenges, given the differential in diagnostics and the reimbursements there versus therapeutics, obviously, the finance is all pushed towards the therapeutic side. But there are certain kind of diagnostic categories that really span many, many diseases. For example, if we could develop targeted agents for fibrosis, that's something that's valuable in the lung and in the liver, and in the in many different organ systems. Similarly, targeting something like thrombosis is something that we see in a wide variety of kind of clinical scenarios. So my guess is that in those settings, we might have the economics of the cost of development, kind of balance out against the utility, and then perhaps over time get some of these more disease-specific agents. But I think there is a wide variety of these kind of general purpose agents that span many diseases, many in the brain, but not just the brain, that would be of great value. In the brain, for example, a neuroinflammatory marker. We're using this in experimental settings, from Alzheimer's disease to autism to ALS to MS to chronic pain. So a marker for that, which is not a single disease, but which really spans a wide range of disease, again may have broader the finances might hopefully work out a little better.
So this question represents, I think, a small protest that the writer is correct that the nervous system isn't just the brain, and asks if we could comment on recent advantages in neurodiagnostics relevant to peripheral nervous system. Comments, brain may be central, but many disease states, including pain, originate in the periphery. What do we got for the periphery?
One that comes to mind is vagal stimulation of the spleen, where you can actually look at some of the autoimmune type things that maybe have their origin in the spleen, and there's already some early data that maybe some stimulation of the spleen can address some of the autoimmune diseases. I can imagine that there are many, many others as well. That's just one example, but there's been some interesting research along those lines. And then, we've heard a lot of other things this morning about deep brain stimulation, but you can also do other electrical stimulation. So there's been stimulation to the GI tract.
So on the treatment side, we've got tools. On the diagnostic side, anything that's
it's
emerging?
interesting. From the pathology of peripheral nerve, we have seen over the last 10 years the number of diagnostic nerve biopsies plummet. And the reason is largely genetic testing and serological types of tests that have replaced the need to take a small nerve, mostly out of the foot, for analysis. So the actual opportunity to learn about peripheral nerve disease from tissue in living patients has actually gotten less from a pathology perspective over the last decade and a half.
I think it's also interesting that many conditions, for example, chronic pain conditions, lower back pain, knee pain, they have origin and a local peripheral thing, but the chronic condition seems to be associated with central nervous system, changes. So not to
say we don't have to look there, but
there may be some very important insights that we can gain looking centrally, even at peripheral conditions, and certainly in the notion of autonomic stimulation, whatever. Again, whether the appropriate entry point for therapeutic is centrally or peripherally may vary by condition, but they are connected.
So we've got a few minutes left. One question is, what is new, or what are you doing new to characterize Alzheimer's disease? And I suppose that must be an imaging question again.
Imaging from multiple. So obviously there's beta amyloid imaging. In the background there's some tau PET markers as well. But again, this is a multimodality. So if you look hippocampal size, both Sarah and Bruce will speak to that, and being able to look at it early. So I think there's quite a bit being done from the imaging point of view to be able to diagnose Alzheimer's disease earlier.
It'll be especially challenging now that we have these molecular markers for amyloid and tau. We're going to be identifying patients that are at risk. The drugs, with luck, seem to be working in some set of patients, but we know that many patients live, for decades with their amyloid, and given the costs involved and the risks of these drugs, these are probably not the patients we wanted. So, we're going to get a point where we can identify patients that might benefit, but we need to figure out which patients actually need the drug because they will undergo this. And that's why I suspect it's going to be a combination of other molecular, markers, maybe other kinds of, tools like quantitative, morphometric analysis that we can do with, high quality MR to actually, look longitudinally to see if patients actually are showing the neurodegeneration that their molecular markers would suggest they might be at risk for. But we're going to need to combine things, somewhat more creatively than just the single molecular, marker of, say, amyloid in the brain. It's not going to be sufficient to tell us who we should treat and who we shouldn't.
Sorry, Jeff.
I think that there's still a huge need for phenotyping, as we've talked about before. The fact is that we used to lump many things into Alzheimer's, and we now know there's separate things like frontal temporal dementias and other types of disorders. And the more we continue to map out the molecular diagnostics, whether it's deep sequencing or transcriptomics or proteomics, along with imaging, and mapping that out so that we can stratify those different patient populations, will be what most effectively helps us develop those therapies and target those therapies to the right people, as opposed to doing it more generically.
So maybe last question. Some of our neuroscientists now have access to these in vivo microscopes, that, like Inscopix, I think is the name of one, where you can actually look at a small number of neurons interacting in vivo in real time, I guess in rodents. Is that a technology that will be useful to and come to humans one day and solve some of these challenges?
I can't speak to the nervous system specifically, but we do use in vivo microscopy already for looking at the lower esophagus GE junction for diagnosis of Barrett's esophagus, where we can image down to a few cells thick. The other area that it's been used is in the coronary arteries to image plaques and stents in place, and that's currently in use now. Either experimentally or an early kind of clinical use. I don't know of any applications in the nervous system.
Well, so Natalie Agar spoke this morning, and she talked about the NMR that's being used in vivo in our operating suite to look at where brain tumor is, and not as the surgeon's actually operating. So I think there are different modalities that are coming to use.
Okay, so we just hit double zeros. We're out of time. I want to thank everybody for their questions and for their attendance at our panel, and hope you enjoy the rest of the evening. Thank you very much. Thank you, panel.